Okay, so this is the quickest way for me to explain side effects of the typical antipsychotics. So, what are we treating with typical antipsychotics? It's probably something you should all know by now. Essentially, the most common question you're going to get is someone with schizophrenia. From there, you can also treat typical antipsychotics for psychosis, bipolar, delirium, Tourette's, acute mania. But as we're starting out, the two biggest things I want you to have at the top of your head whenever you read typical antipsychotics is always going to be you want to make sure you use with caution in dementias. That's like a big no-no. If you try to do that in clinical practice, you'll probably lose your license, or if you don't think about it, at least. So dementias, so these people cannot be taking typical antipsychotics. And then as well as all these typical antipsychotics are going to prolong your QT. For anyone who wants to read a little bit more on why, I suggest you read about the potassium effects of antipsychotics, but that's a whole separate thing. It kind of makes sense when you bring the whole big picture together. But anyways, typical antipsychotics can prolong the QT. That goes for all of them. So you have your high potency and your low potency ones, right? You see them all listed out there. But where I want you to focus first is over here where it says cholinergic and let's see, hold on. Let me highlight this. So you have your cholinergic system, right? In your brain, you have acetylcholine. You also have dopamine, okay? I have these triangles, and what these triangles are showing is the amount of activity. So if you have a lot of cholinergic activity, for these questions, okay, this is for these questions, I want you to think that there's very little dopaminergic. So specifically, these high potency drugs are really good at blocking dopamine, right? So that means you have a very low dopaminergic effect. Whenever you have a low dopamine or you're blocking dopamine a lot, you're going to get more cholinergic effects. And what are these effects? The big one is prolactinemia. If you're blocking dopamine a lot, you're going to get those extrapyramidal effects, okay? So everybody has their own acronym. I use DAPT, okay? And you can use this image to remember like what it's actually for. So for high potency, again, you're going to have prolactinemias. Specifically, the thing you're most worried about is these extrapyramidal effects. You're going to get that a lot with someone who has dementia, right? You're going to get these blockage effects of dopamine. So when looking at this, Haldol or haloperidol is probably not the best idea for somebody who already has low dopamine. Who's that going to be? The person with dementia, right? So this is going to be somebody with, for example, Parkinson's or all the dementias, really. You need to know that the dementias in general should be avoided in high potencies, right? So you're not going to get somebody like that and have them straight up on Haldol or flufenazine. They like to ask about the flufenazine because that also blocks the D2 receptor. Alternatively, if you want to use a low potency, it's still going to block your D2 receptors, but a lot less than your high potency ones. You're going to have way more blockage of the cholinergic. You're less likely to have a hyperprolactinemia. The two big ones are thioridazine and chlorpromazine. Thioridazine, the big adverse effect, well, aside from the anticholinergics, are going to be brown vision with retinal deposits. And the chlorpromazine, which is often used for hiccups. It's blocking your alpha 1, so you have to just expect that it's going to cause orthostatic hypotension, sorry. But here, so for example, the question you might get, so these are the anticholinergic effects, which is, I use this to remember what it stands for, which is decreased sludge, which is decreased salivation, lacrimation, urination, defecation, and sweating. I'm thinking I'm already forgetting the other S. But anyway, so your anticholinergic effects. So they're going to have a lot of a downplay of all these things here. Alternatively, they're not as likely to get the extrapyramidal effects. So you could get a clinical vignette in which someone says, this patient has prolactinemia. Which of the following are they most likely taking? And you're going to want to say haloperidol, okay? Or you may get a vignette that says this patient has dementia. Which one do you want to give them? And they're going to give you, if they give you this list, for example, you would want to pick something on the lower potency. If they say patient's taking one of the following drugs and is experiencing akathisia, right? Which ones are those going to be? Your D2 blockers, right? Or they could tell you this person is taking a highly dopaminergic blocking drug that is causing akathisia. And they may tell you, what is this drug likely to cause? Okay, that's going to be prolactinemia. Anyways, that's a pretty much easy way of remembering those two systems. And that pertains to a lot of different things, so I hope it helps.